on the table. So we'll go right into the lumbar spine exam. I'm going to have you go ahead and stand up for me, please. And, what's that? Yeah. And then I'll eventually have to expose the knee and take a socket shoe off too. But that's what you get for being the mama. All right, so stand up for just a second. You're fine, no worries. All right, so what I'll often do is stand next to the patient. You want your feet about shoulder width apart. I'm going to do active flexion, so keep your knees straight. Reach down, touch your toes or the floor. Good. Come on back up. Go ahead and I usually rest my hand in the small of the back, arch back, lumbar spine extension. Good. I'm going to come around in front of you a little bit if you'll just angle towards me just for video's sake. We'll do side bending or lateral flexion. You're just imitating my motion, so active lateral flexion. Good. And then hands on the hips and just rotate in one direction, rotate around the other direction. Trunk rotation. So that's active lumbar spine range of motion, straightforward stuff. We don't have any resistive range of motion we need to do. What I will do is have you turn around and face that way a little bit for me, just for the group. So palpation landmarks in the lumbar spine are basically the spinous processes. I'm going to pull this up a little bit. I usually start up and kind of work my way down the midline, and I'm on the spinous processes here, walking all the way down to the top of the gluteal cleft. If you look at the lower back, and he has this, you can almost see a little bit of sacral dimpling on each side. That kind of helps you find the SI joint. So I want to mention that when you're looking at the skin surface, sometimes you can see those things better. But since you're already back here and you don't really have a whole bunch of lumbar spine palpation points, you can go ahead and palpate the iliac crests. You can come straight down and go ahead and do the greater trochanter if you want, because it's going to be right directly parallel to that. The SI joint is near those sacral dimples, and I'll do it over top so you can see. This is essentially SI joint right here, SI joint here, okay? And then we talked a little bit about ischial tuberosities. Sometimes you can have your patient kind of try to poke and find their butt bone for you. Think you can poke on your butt and find your butt bone? That's your ischial tuberosity. All right, gotcha. Pardon my reach. And poking. There it is in there. All right, so you gotta push in pretty far to get there. Okay, that's the ischial tuberosity. And if you just move lateral a little bit, you're going to get into deep in the gluteal muscles into the sciatic notch and where the sciatic nerve is at. Okay? All right. So we went ahead and tackled some of the lumbar spine and hip palpation points while we were there. I need my sheet as a checklist. I have to remember if I'm on track or not. I'm going to grab mine because I've got some cheat sheet stuff on here. All right. And yeah, we got SI joint, ischial tuberosities, sciatic nerve, all of that while we were there.
Yes, that is.
I can go ahead and do anterior landmarks now, including the anterior superior iliac spine where my thumbs are at on each side. Okay, that's a hip flexor attachment. So we got all the hip and lumbar spine landmarks while we were there at least. Go ahead and sit on the edge of the table for me. From a spine standpoint, the special tests are straight leg raising. Seated straight leg raising is you as the examiner passively extending the knee, supporting the back, and lifting that leg up. You want to know if that reproduces any pain at all. If they do say it reproduces pain, you want to know where they feel it and what they're feeling. Is it just a stretch in the hamstring, which is pretty common, or are they feeling some numb, tingly electrical stuff down to their foot? Go ahead and scoot back and have you lie down, supine or on your back. Square just a little further. You still got a few inches here. Yeah. There you go. Watch your hand. Good. All right. So supine straight leg raise, same type of test with them supine and relaxed. A lot of times I'll rest my hand on the front of the pelvis as I lift that leg up. And as it starts to tighten up, which will happen with hamstring tightness anyway, you want to know if that's reproducing any pain or anything down into the lower leg or foot. Anything at all? Okay, good. A lot of times if that's reproducing pain down here, a lot of times they'll start to move their pelvis around a little bit to adjust and take tension off of it. So that's a negative supine straight leg raise. While you have them in this position, you might as well go ahead and do that special test for the SI joint. Bring your foot across your knee. This is a FABER. We flex the hip, we abduct the hip, we externally rotate the hip. We're going to go ahead and do a Faber test. I'm stabilizing the ASIS with one hand, the knee with the other. I'm going to put downward pressure. That cause any pain at all? Okay. If it does cause pain, you want them to clarify where they're feeling it. Do they feel it in their back or do they feel it in their hip, for example? Is it in the groin? If it's in the groin, that's not a positive favor. Okay, if it's in the back, that's a positive favor. So that's for SI joint. All right. And while I've got you in this position right here, we'll transition right into the hip exam. So active range of motion. I just want you to bend that knee and pull it up towards your chest. That's active hip flexion. Straighten your leg back out. Go ahead and just swing this leg straight out to the side. That's active hip abduction. Swing it across this other foot over the top. Active hip abduction. Go ahead and bring it up to about 90 degrees. So this is the hip inflection. I really think we should be testing internal and external rotation more passively. Passive external rotation, passive internal rotation. Since all of your motions you guys are doing on checkoffs are active, you can always try to tell the patient, okay, rotate your leg outward for me, like that. So that's active external rotation, but you might have to help them a little bit. Turn your leg inward, hold it right there. That's more of an active internal rotation, okay? But I just think passively it makes more sense, all right? All right, grab on, sit you up, come up to the edge of the table. When we move on to the resisted range of motion, I like to do it seated because you can really test both legs a little easier. We'll just do this one first. I just want you to lift the knee up in the air. I'm going to pull down. This is resisted hip flexion, okay, and relax. I'm going to put my hands on the outside of your knees. I want you to spread both knees apart. That's resisted hip abduction. I'm going to put my hands in between your knees, and I want you to squeeze my hands together. That's resisted hip adduction, or bringing those together. I think I've covered all of the hip stuff on there. Correct me if I'm wrong. All right, so we're in this position. I'm already down here for a knee exam. That's your bad knee?
Yeah, I want to see.
All right.
This one.
I think it's a hot mess. I'm just kidding. Yeah, exactly. All right, so active range of motion of the knee. I'm going to have you basically extend the knee out straight. Good. Go ahead and bend it back as far as you can. You can always have them bring it up towards your chest so I can see if you can bend it a little bit deeper. Yeah, so you can kind of test flexion a little better if you let them pull it up that way. That's your active range of motion of the knee. Resisted range of motion, if you'll push out towards me. Good. That's resisted extension. And then pull back towards the bed. Good. Resisted flexion. When we move on to landmarks, I like to break it up kind of into sections, so to speak. We're going to start with the patella itself. You can palpate over top of the patella, which in front of it would be the prepatellar bursa. We have the infrapatellar tendon coming down to the tibial tubercle. We then have two soft spots on the knee. One on the medial side, one on the lateral side. That's how you find the joint line, so you know where you're going to palpate for the joint line and the meniscus. So I'm going to start lateral over here. Let's just assume his pain was medial, so I'll start away from the pain. Lateral joint line, walking your fingers around to the back side of the joint, and you guys will get to see that on the medial side when we do it. Lateral meniscus would all be deep to this. If we go up to the lateral epicondyle, the lateral collateral ligament runs from the lateral epicondyle down to the fibular head. So that's your LCL. If you come anterior, his knees are bony enough where you can see the lateral tibial tubercle. This right here is Gerdy's tubercle. This is where the IT band attaches. Okay? If we go medial, got that soft spot again, medial joint line, walking along the medial joint line towards the back of the knee, medial meniscus all the way from front to back. We then get on the medial epicondyle and the MCL through here. Just anterior to where that MCL attaches towards the knee over here is more of the pes anserin attachment. There it is right there. Feel it right underneath. Bony bump right here. That's the pes anserin tendon attachment, and the bursa is underneath that. Okay? Posteriorly, we have the popliteal fossa. You always want to make sure you scoot out just an inch or so. That's perfect. You just want to make sure you can feel in the popliteal fossa and that you don't feel any cyst or mass or anything unusual in the back of the knee itself. So once we've gone through active range of motion, we've done resisted range of motion, and we've done palpation, we move on to special tests. So I'm going to let you scooch back there. Lay there, watch your head. You're good. All right. I'll start with allotment which is basically I want to determine whether or not he's got any fluid on the knee itself. What you're going to do is kind of start mid to distal thigh, and you're going to kind of milk the knee downward a little bit, so that if there's fluid in it, it should raise the patella up a little bit, and then you push the patella down to see if it's really bouncy or not. That's usually better for a subtle effusion. If it's a significant effusion, like an acute knee injury, like an ACL, you're not going to need to do a Ballottement test. You're going to look at it and say large effusion. Okay, but that Ballottement test is just pushing down on the kneecap after you've pushed the fluid down. Okay. We then go on to ligament stress testing. We do varus and valgus stress testing. When we do these, we do them at 0 degrees and 30 degrees. So what we'll do is I'll start with valgus stress testing. We're going to get the knee straight. You're going to support it with one hand, put the palm of your hand on the outside of the knee, and put a valgus stress. So if I'm doing valgus stress, I'm testing the integrity of the medial collateral ligament. You do it at 0 degrees, and then you can bend it up a little bit and do it at about 30 degrees. What that does is tests different fibers of those respective ligaments. So as I come around to do varus stress, I'm just supporting it. I'm going to push on the medial aspect of the knee, putting varus stress on the knee for the lateral collateral ligament at 0 degrees. I'm going to bend it a little bit, do the same thing, and do it at 30 degrees. So that's varus and valgus stress for the collateral ligaments. Now, from a cruciate ligament standpoint, we want you to try to learn how to do a Lachman test, but I will tell you it's going to be hard for some of you to do them on certain patients, either based on your hand size or the leg size, and that's where the actual anterior drawer test can be used instead. So I'm going to show you both. Lachman-wise, I'll let you put this one down just to get that as relaxed as possible. It's always good to have their hands on their belly and their head down so they're not guarding and watching it all. He's been through this enough so he knows. But what you want to do is support the thigh with your top hand, depending on what side of the body you're on. But I'm really not gripping him too much here. Most of your gripping is going to take place down below on the tibia and fibula. As I pull forward or anterior with my lower hand, I'm pushing backwards just a little bit with my top hand as a counter force so that I'm not just pulling his whole leg up and down. So as I do this here, he has excessive play of his knee anterior to posterior. Okay. Consistent with somebody who's had a reconstruction or multiple. And a reconstruction I'm not sure is working. Yeah. I'm just kidding. And then we go ahead and we take you up into this position here, and this is 90 degrees, and this is how we would do an anterior drawer if I couldn't get my hands around him or get a good exam. Now I am going to show you his other knee just so you can see how much play he has on this side versus that side, so you can appreciate that a little more. And when I do this, I usually go ahead and kind of sit on the foot a little bit just to stabilize the lower leg so it doesn't slide. But this test right here is also for the ACL, and if you can get him to relax enough, the hamstring tendons, no, you're good. The hamstring tendons right here will relax, and you can actually do, okay?
Wow.
Okay, so that's a anterior drawer. Sorry. So I'm stabilizing it, but a lot of it is me rocking back with my body weight, okay? And remember, a normal anterior cruciate ligament should not allow the lower leg to slide forward that much, first off. Now, when you're in this position, you could do a posterior drawer, which is what tests the PCL. He has no play posterior, but extra play anterior, just to show you the difference, okay? I won't keep doing that. But no, it's good. That's all right. While you're there, let me do this one. And let's rest it down. Let's try Lachman on him first, see if we can see a difference. You have to pause your thing, I don't know, but
It's all right.
almost nothing. I've got no significant play there. Going back over here. He's loving this, I know. He's been through this so many times. Okay. I just want the audience for gotcha. All right, grab on. No worries.